Hello everyone, today's lesson is about Amebiasis. Four morphologically identical but genetically distinct species of Amoeba are known to infect humans. They are Amoeba stolotica, Amoeba disper, Amoeba moshkovsky, and Amoeba bangladesh. Amoeba stolotica is the main pathogenic species and can become invasive in 4 to 10% of infected patients. Epidemiologically, infection with Amoeba stolotica causes 100 million cases of symptomatic disease and 2,000 to 70,000 deaths annually. 4 to 10% of individuals infected with Amoeba stolotica develop Amebic Colitis, and less than 1% of infected individuals develop disseminated disease, including Amebic liver abscess. Amebic liver abscess occur equally in male and female children, but they are generally rare in childhood. Regarding pathogenesis, infection is acquired through the ingestion of the parasite cyst, and the cysts are resistant to the harsh environmental conditions, including chlorine concentrations used in water purification, but they can be killed by heating to 55 degrees Celsius, and they are also resistant to gastric acidity and digestive enzymes, and they germinate in the small intestine to form the trophozoites. And the trophozoites are responsible for tissue invasions and destruction. These large, actively motile organisms colonize the lumen of the large intestine. Once attached to the colonic mucosa, trophozoites penetrate the epithelial layer, destroying host cells by cytolysis and the induction of apoptosis. Cytolysis is mediated by the trophozoites by the release of amoeba pores or pore-forming proteins, phospholipases, and hemolysins. Phagocytosis, where amoeba ingests pieces of living cells and induce intracellular calcium elevation, leading to apoptosis, is a mechanism for direct host cell killing by amoeba. Once Amoeba stolotica trophozoites invade the intestinal mucosa, the organism multiply and spread laterally underneath the intestinal epithelium to produce the characteristic flask-shaped ulcer. And amoeba produce similar lytic lesions if they reach the liver. Well-established ulcers and amoebic liver abscess demonstrate little local inflammatory response. The disparity between the extent of the tissue destruction by amoeba and the absence of local host inflammatory responses in the presence of systemic humoral or antibody and the cell-mediated response might reflect both parasite-mediated apoptosis and the ability of the trophozoites to kill not only epithelial cells but neutrophils, monocytes, and the macrophages. So we can classify the pathogenesis of amebiasis into two, non-invasive and invasive. In non-invasive one, amoeba colony are formed on the intestinal mucosa, and the patient might be asymptomatic cyst passer, or they might have non-dysenteric diarrhea, abdominal cramps, and other GI symptoms. Whereas in the invasive case, there is a necrosis of the mucosa, which causes ulcers and dysentery, and ulcer enlargement causes dysentery and the peritonitis. And also there might be metastasis into the extraintestinal sites, like lung and other sites. When we see the clinical manifestations of amebiasis, there are three types of clinical presentations. The first one is, and the most common one, is asymptomatic cyst passage, and the next one is amebic dysentery, and the other is amebic liver abscess and also extraintestinal disease. Up to 10% of infected persons develop invasive disease within a year, and asymptomatic carriers should be treated always. Severe disease is more common in young children, pregnant women, malnourished individuals, and the person taking corticosteroids, and invasive disease is more common in men. That might be due to the immunosuppressant effects of the testosterone. More than 90% of amoeba cases are asymptomatic, whereas around 10% might have amebic colitis or amebic liver abscess. Amebic colitis may occur within 2 weeks of infection, or they might be delayed for months. And the symptom is gradual onset of colic abdominal pains and frequent bowel movement 6 to 8 times per day, associated with tenesmus. Almost all stool is Hem positive, but there might or might not be grossly bloody stool. Fever documented in only 1/3 of patients, and amebic colitis is more common in children 1 to 5 years of age, but it can occur at any age. But the most common age is from 1 to 5 years of age. The other is about amebic liver abscess. Amebic liver abscess is uncommon in children, and it occurs in less than 1% of infected individuals, and it may appear in patients with no history of intestinal disease. In children, fever is the hallmark of amebic liver abscess, and it is associated with abdominal pain, abdominal distension, and enlargement, and also tenderness of the liver. Changes at the base of the right lung, such as elevation of the diaphragm, and atelectasis or effusion may also occur. Regarding laboratory findings, lab examinations are often remarkable in uncomplicated amebic colitis. Laboratory findings in amebic liver abscess include slight leukocytosis on CBC, moderate anemia, high ESR, and also elevation of hepatic enzyme levels, especially alkaline phosphate. Stool exam is negative in more than half of patients with documented amebic liver abscess. Ultrasonography, CT or MRI can localize and delineate the size of the abscess cavity. The most common finding of amebic liver abscess is a single abscess in the right hepatic lobe. A diagnosis of amebic colitis is made in the presence of compatible symptoms with detection of Amebiasis stolotica either by stool antigen testing or PCR with greater than 95% sensitivity and specificity. Microscopic examination of stool samples has a sensitivity of 60% if it is only a single stool test. We can increase the sensitivity by requesting stool exam 3 to 4 times. The sensitivity can be increased to 85 to 95% by examining 3 stools. So if the first stool microscope is negative, we should have to repeat the stool microscope. Microscopy cannot differentiate between Amebiasis stolotica and Amoeba dispar unless phagocytosed erythrocytes, which is specific for Amebiasis stolotica, are seen. Endoscopy and biopsy of suspicious areas should be performed where stool samples are negative and the suspicious remains high. The top differential diagnosis for amebic liver abscess is pyogenic liver abscess. Pyogenic liver abscess is most of the time multiple and it's located in both lobes equally, whereas amebic liver abscess is usually found on the right hepatic lobe and most of the time it's usually single. When we see the complications of amebiasis, complications of amebic colitis include acute necrotizing colitis, ameboma, toxic megacolon, or extraintestinal extension or local perforation in the peritonites. An amebic liver abscess may rupture into the peritoneum, pleural cavity, skin, and the pericardium. Rarely, amebic abscess in extrahepatic sites, including the lung and the brain, can happen. When we see treatment of amebiasis, invasive amebiasis is treated with nitroimidazole, such as metronidazole or tinidazole, and then luminal amebicides. Tinidazole has similar efficacy to metronidazole with shorter and simpler dosing, and it is better tolerated. Therapy with nitroimidazole should be followed by treatment with luminal agents such as paromomycin or dioxanide furet, which can be used for greater than 2 years of age. Paromomycin should not be given concurrently with metronidazole or tinidazole because diarrhea is a common side effect of paromomycin and it might confuse the clinical picture. Asymptomatic intestinal infection with Amebiasis stolotica should be treated, preferably with paromomycin or alternative with idoquinolone or dioxanide furet. Broad-spectrum antibiotic therapy might be indicated in fulminant colitis to cover possible spillage of intestinal bacteria into the peritoneum and the translocation into the bloodstream. Intestinal perforations and the toxic megacolon are indications for surgery. In amebic liver abscess, image-guided aspirations of large lesions or left lobe abscess might be necessary if rupture is imminent or if the patient shows a poor clinical response 4 to 6 days after administration of amebicidal drugs. Chloroquine, which concentrates in the liver, might also be useful adjunct to nitroimidazole, the treatment of amebic liver abscess, or in case of treatment failure or intolerance. To confirm a cure, stool examination should be repeated every 2 weeks following completion of therapy until clear. When we see drug treatment for amebiasis with specific doses, metronidazole is given in the dose of 35 to 50 mg per kg per day in 3 divided doses for 7 to 10 days for both colitis or liver abscess. And the tinidazole is given in the dose of 50 mg per kg per day once daily for 3 days if it is colitis or for 5 days if it is liver abscess. This is followed by paromomycin and dioxanide furet, which is given for 7 days, both of them. Amebic liver abscess treatment can be drug therapy alone if the size is less than 6 cm. If there is no features of rupture or no compression effect, or symptoms subside after 48 to 72 hours of treatment. And ultrasound guided aspiration can be done if there is features of impending rupture and the size is greater than 6 cm and the multiple abscess involving both left and the right lobe, and also failure in the improvement and aggravation on conservative treatment even after 72 hours. Criteria for percutaneous drainage include failed ultrasound guided needle aspiration or features of secondary infection. And criteria for laparotomy and drainage for amebic liver abscess include ruptured abscess in the peritoneal cavity, features of peritonitis, and the complicated amebic liver abscess, which is ruptured in the superior and the peritoneal cavity. When we see prognosis and the prevention of amebiasis, most infections evolve to either asymptomatic carrier state or eradication. Extraintestinal infections carries about a 5% mortality rate. Control of amebiasis can be achieved by exercising proper sanitation and hygiene, and a regular examination of food handlers through investigation of diarrheal episodes may help identify the source of infection. And no prophylactic drug or vaccine is currently available to prevent amebiasis. Thank you for your attention. Have a nice time.